Very well, thank you. Thank you for inviting me and including me in the program.
Thank you for accepting our invitation. We are honored. We'll just begin in a minute or so.
Okay.
Just introduce you and then you will share your screen.
Okay, that sounds good.
Can we start, sir?
Yeah, sure. Go ahead.
So you can start in 3, 2, 1. Please go ahead, sir.
Good evening, friends and colleagues from India, and good morning, good afternoon to those who are logged in from the rest of the world. eACE, the 5th Academy of Clinical Experts, an update in hematology and hemato-oncology, brought to you by Mumbai Hematology Group, supported by Novartis and managed by Perfect Square. I thank Mr. Rahul, Mr. Dinesh, Lekha and the team from Novartis, Yash Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speakers for day 3, Dr. Robert Zieser from Germany and Dr. Pefo de Lauto Regis from France. All our discussants were themselves eminent hematologists, medical oncologists, or transplanters. And you participants for sparing your valuable time on a Friday. Today is day 3 of this marathon webinar. The session 1, we have the lecture on when do I use ruxolitinib in the treatment of graft versus host disease. And the guest speaker is Professor Dr. Robert Zieser. He's from Department of Medicine 1, Hematology and Oncology, Head Section of Tumor Immunology and Immune Modulation University, Medical Center, Freiburg, Germany. This will be followed by the panel discussion, which will be moderated by Dr. Arijit Nag from Kolkata. And we have panelists whom I will be introducing at the time of the panel discussion. So over to Dr. Robert Zieser for his lecture on when do I use ruxolitinib in treatment of graft versus host disease.
Thank you very much for the kind introduction. So I hope you can all see my screen now.
Yes, sir.
Great. So my question is, when do we use ruxolitinib in the treatment of graft versus host disease? First of all, I would like to show you what graft versus host disease means for our patients. So graft versus host disease is a complication of the allogeneic stem cell transplantation, and it typically affects the skin, the intestinal tract, and the liver. And here you can see an endoscopic image of a patient that has intestinal graft versus host disease. You see here the mucosa is damaged, and you see hemorrhagic lesions in the mucosa. This is early when graft versus host develops, and this is more advanced when you have multiple bleeding sites. You can imagine that this is painful and dangerous for the patient because of the transmigration of bacteria. When you take a biopsy, you would find infiltration with immune cells, T cells, but also innate immune cells like neutrophils that damage the tissue, and some of those neutrophils you can find in the lumen of the crypt, as you can see here. And this is a classical view of graft versus host disease target organs. As I said, the skin, the liver, and the intestines have been investigated, but there's more and more evidence that not only these 3 organs, but also the central nervous system, the lymph nodes, thymus, lungs, kidney, ovaries, testes, and bone marrow are involved, and those different cells are also target cells of graft versus host disease. So what do we do to treat acute graft versus host disease? We first of all treat this disease with so-called glucocorticoids, and this treatment has a response between 40 to 50%. The problem is that only a fraction of patients has a long-term response. A large portion of patients experiences only short-lived responses. Does this GVHD impact survival? And here you can see the survival graph. You can see that the group that achieves a complete remission or partial remission, so a corticosteroid responder, has an improved survival as compared to the other patients. We follow the treatment guidelines when we treat patients with acute graft versus host disease provided by the EBMT and ELN. And you can see here that those patients receive systemic methylprednisolone at a dosage of 2 milligram per kilogram body weight divided into dosages for 7 days. If there's no response after 7 days or clear progression after 5 days, these patients need to receive second-line therapy or be included in a clinical study because they count as corticosteroid-resistant patients. And patients that respond, of course, you can taper the corticosteroids. It is currently not clear how fast that should be done. We have a while ago started to develop a new therapy for graft-versus-host diseases. Therapy is based on the inhibition of Janus kinases, which are downstream of cytokine receptors. As you can see here, JAK1, for example, is responsible for downstream signaling of IL-6 or interferon gamma, which are key cytokines in the pathogenesis of GVHD, and we know that they activate start proteins that then activate pro-inflammatory effects. Here we had shown in the mouse model that mice that receive ruxolitinib, here in the black bars, they have an improved survival as compared to the control group that receives vehicle only, and the weight loss is less prominent in the ruxolitinib group as compared to the vehicle group. Also, the histopathological signs in the vehicle group were more prominent as compared to the ruxo group, which prompted us to then treat patients. And we treated several patients, and one of those I would like to present you. This is a 65-year-old female patient who presented to the emergency room with leukocytosis, low platelet counts, and low hemoglobin level, and a highly elevated LDH. The diagnosis of an acute myeloid leukemia was made with an unfavorable prognosis because this leukemia carried a complex karyotype as well as a FLT3 IDD mutation. After induction of with chemotherapy 3+7, there was an induction failure in this patient, and the patient received salvage therapy with a CLAM protocol and was still not in remission, then underwent allogeneic stem cell transplantation. Here you can see the skin graft-versus-host disease of this patient that developed already on day 23 after transplant. You can imagine that this is a terrible condition where the skin is peeling off, and that's of course also painful and makes the patient highly susceptible to infections. This patient was included in the REACH trial and randomized in the ruxolitinib arm. Patient skin recovered, as you can see here, already after 8 days of ruxolitinib. So it was a strong improvement, and as you can see here, this improvement continued until the patient achieved a complete remission with respect to the GI GVHD and the skin GVHD. So here, this patient was a successful ruxolitinib patient. Importantly, also the high-risk leukemia remained in remission in this patient. This is another patient that received corticosteroids and cyclosporin A for the treatment of intestinal GVHD, and this patient didn't respond. After several days, ruxolitinib was added, and as you can see here, the patient then achieved a response with a decline of the times of diarrhea per day. And a biopsy before the addition of ruxolitinib showed dense immune cell infiltration, and that improved later with less immune cell infiltration and the recovery of goblet cells. Here is then the prospective randomized phase 3 trial, the REACH-2 trial, where ruxolitinib was compared to best available therapy for glucocorticoid refractory acute GVHD. And as you can see here, the patients receiving ruxolitinib had an improved response rate over patients receiving best available therapy. This was highly significant, and so was also the failure-free survival, where we observed an improved survival in patients receiving ruxolitinib compared to the control arm. Of course, every effect has also side effects, and in patients that were treated in the rux arm, there was an increased risk of thrombocytopenia. So any grade of thrombocytopenia percentage was 32%, in contrast to 27%. This difference is not so big, in contrast to 18%, sorry. And the high rate of thrombocytopenia was 27 versus 50%. That was highly significant. So thrombocytopenia is a concern. This is not unexpected because thrombopoietin receptor signaling depends on JAK2, and we are inhibiting JAK2. The other side effects were not different in the groups. In particular, interestingly, also no change in CMV reactivation in these heavily pretreated patients. So the question is, when do I treat patients with ruxolitinib when they have a GVHD? So they need to have a platelet count above 10,000. That is required in my view because that predisposes them otherwise to bleeding. They should not have an active uncontrolled virus infection. Sorry, like a CMV retinitis, pneumonitis, for example. And of course, patients should be without active bleeding. If they have a history of ruxo intolerance, this would also be a reason not to treat them. So this is extremely rare. I haven't seen a patient with ruxo intolerance, but these are clear reasons not to treat. And then the next question is, which patients do I treat with ruxolitinib? So basically all patients with steroid-refractory acute GVHD, except those that I had named before. And I would also emphasize that we also treat patients that had been treated with ruxolitinib and failed, and then had received other therapies. And a reinstitution of ruxolitinib in combination with other immunosuppressive agents can even be synergistic. For example, the combination with extracorporeal photophoresis. And I here would like to show you an example. ECP has probably a different mechanism of action compared to ruxolitinib. It is known that ECP is based on the effect by apoptotic cells that are being infused in the patient, and this induces tolerance, induces myeloid cells to be more tolerant, and increases the frequency of regulatory T cells. So here you see an example of a patient with a very refractory skin graft-versus-host disease with this rash here that decreased after the combination of ruxo and ECP. This is before ECP, the intestinal tract, that was then healing after the ruxo-ECP combination in a patient that had been treated with more than 7 drugs. And here you can see the number of patients achieving different responses. So partial response and a complete response are over 70%. There's also a fraction of patients that never responded to this combination. And here you see the organ response rates. You can see that GI tract, skin, and also liver are responding, particularly good the GI tract and liver and skin, sorry. This is a time to response. So this is important because we tend to treat all patients not long enough. Sometimes patients need a very long time. You can see several weeks here until they respond to the combination therapy. So all patients receive corticosteroids, and that is, of course, dangerous because the steroids have a lot of side effects that endanger the patients to die of sepsis or to have high blood pressure, diabetes, peptic ulcer disease, or bone lesions. So we taper the steroids rapidly, and this is good possible if we have the combination here. This is after start of the combination with ruxo-ECP. Also, we see that upon ruxo alone, the IL-2 receptor declined. But in all these patients that had been already on rux, the combination of rux and ECP further decreased the soluble IL-2 receptor, indicating that there's really an add-on effect when combining the two interventions. Here you see the overall survival of these patients was quite favorable. At 24 months, 81%. Overall survival here. Of course, chronic GVHD is not as aggressive as acute GVHD. And these patients had a relatively good outcome for patients that are so chronic GVHD refractory. In conclusion, I have shown you that overall response at day 28 was higher with RUX compared to BAT in patients with steroid refractory GVHD. Durable overall response at day 56 was also significantly higher, as well as a failure-free survival. And the safety profile of RUX was consistent with previous observations in patients with acute GVHD. And based on that, we know that RUX was approved in the US and in Europe for the treatment of steroid refractory graft-versus-host disease. And currently, the guidelines are that we should treat patients that fail corticosteroid treatment with ruxolitinib. There are some exceptions when patients are extremely thrombocytopenic, because this was one of the side effects. And when patients have an active bleeding, as well as an uncontrolled viral infection, then this drug is problematic. But many other drugs are problematic in this situation, because most of the drugs that we use for GVHD are immunosuppressive and interfere with the activity of the immune system against viruses, fungi, or bacteria. With that, I'm at the end of my presentation. I would like to thank you all for the attention, and I'd be very happy to take your questions. Thank you.
Thank you, sir, for that wonderful presentation. We have some of the Indian colleagues here who are transplanters, and they may like to ask their difficulties to you. So those of you who are interested can open your videos and go ahead with the questions. Yes, Dr. Ankit.
We cannot hear you.
Unmute.
Yeah. Good evening, sir. Thank you for the enlightening talk. My question is, sir, in patients who respond to ruxolitinib in the setting of acute GVHD, how do you plan and taper out the steroid subsequently during the course?
That's a very good question. Currently, there is no rule how to do that. The way we do it is we taper it fast, because we believe that if a patient has not responded within 7 days to the steroids, they're not doing anything good for the patient. They are putting the patient in more danger because they make the patient more susceptible to infections. So we taper, we divide by 50% for 3 days. If there is no change, then we further decrease it by 50% for the next days, and then we taper it completely. These are our reduction steps.
Thank you. Dr. Sumit?
Sir, for patients who do respond to ruxolitinib, so how do you plan to taper the ruxolitinib dose in these patients? So, for example, in myelofibrosis patients, when you stop ruxolitinib suddenly, there is a risk of cytokine release syndrome. Is that phenomenon observed in GVHD patients also when you try to taper ruxolitinib?
Yeah, we were very afraid of this cytokine rebound syndrome that was observed in myelofibrosis or P. vera patients. And we have never seen that in GVHD, I must say. We are very careful in tapering the ruxolitinib 5 milligrams every 3 weeks as our tapering strategy. And if a patient worsens during that period of time, we sometimes go back and increase it again, basically.
And what is the maximum dose of... Sorry, sir?
Yes.
What is the maximum dose of ruxolitinib you have used in your patients?
The maximum dose is 2 times 10 milligrams. We are not going higher than that.
Thank you, Sumit. Dr. Dharma?
Hi, good evening, sir. So the question is that we had a patient who is a failed mud transplant, the 10x10 match donor, and then he developed skin and gut GVHD, started on PRAD and subsequently added RUX. So skin and the gut started improving, but his bili started going up. So bili reached 220, and we have excluded all the causes of whatever, liver, including liver biopsy. This is consistent with GVHD. He had a CMV reactivation. Slowly we could brought down the steroid, but his bili is still hovering to 16 to 20. So my question is, have you seen that RUX, respond with the 1 or 2 organ, but sometimes the one organ can escape and not responding?
Yes, we had also seen such patients. that respond just with the gut and not with the skin or with the liver, for example. It's not that frequent. Typically, all organs respond very similar, but we have similar patients, and sometimes you need to continue then with ruxolitinib and add something specific for the liver, for example. So what we typically do is that we give also desoxycholic acid for liver GVHD, and ECP has also some activity for liver GVHD.
So this patient, we use deoxycholic acid from the beginning of all our transplant.
Yeah, from the beginning of the transplant.
For thalassemia particularly. But the two organs improved and one is progressing. And this child, mud transplant, then got CMV, then with the ganciclovir platelet goes down. So ultimately he started having bleeding PR. We have to stop drugs because thrombocytopenia was tune of less than 10,000. So in these patients, how to manage, how common this phenomena with RUX, the two organs respond and progress further.
Yeah, so that is a very rare event in my view. We have, I would say, 15 or 10% of the patients have a response in a single organ only. Most patients respond in all three organs similar.
Thank you. Sir.
Yeah.
Thank you. Thank you, Dr. Dharma. Any other questions from anybody? Okay, so there aren't any more questions. Dr. Arijit, are you ready to start the panel discussion?
So I'll still need about 7-8 minutes.
Okay, fine. So, okay, we have a little break for 7 minutes and then start the panel discussion at sharp 7:30 p.m. And Dr. Robert, thank you very much for being with us. And I'm not sure if you are free, you can be with us for the panel discussion.
Yes, I will be there.
Oh,
thank you very much
Great.
for the kind invitation.
So 7:30 we will begin. Fine.
So I'm ready to start whenever.
Kalpesh?
Yes, sir, ready, sir.
Okay. You want to give the signal?
Yes. Dr. Nath, are you ready?
Yeah.
Yeah, can you please open your video?
Yeah, sure. Just wait.
So you can start in 3, 2, 1. Please start.
Okay. Good evening, everybody. Sorry for that snag for 5-6 minutes. So we'll start our presentation today. It's a panel discussion on when and how I use ruxolitinib in the treatment of GVHD. And with us today, we have our panelists, which include Dr. Suparna Chakraborty. He is a senior consultant and HOD in hemato-oncology and BMT in Dharamshila Narayana Hospital, New Delhi. We have Dr. Sarita Rani Jaiswal, who is a consultant in hematology and BMT and is the program director for haploidentical BMT program at Dharamshila Narayana Hospital, New Delhi. We have Dr. Dharma Chaudhary with us, who is senior director and HOD for Center for Bone Marrow Transplant at BLK Max Super Specialty Hospitals, New Delhi. We have Dr. Sharad Damodar, who is a senior consultant hematologist and head of adult hematology and BMT at Mazumdar Shah Cancer Center, Bangalore. We have Dr. Revati Raj, who is a senior consultant in pediatric hematology and BMT in Apollo Hospitals, Chennai. We have Dr. Rajiv Dey, who is professor in the Department of Hematology at NRS Medical College and is the clinical lead in BMT program in Narayana Super Specialty Hospital, Howrah. We have Dr. Sunil Bhatt, who is the director and clinical lead of pediatric hematology, oncology, and BMT at Narayana Health Network Hospitals. We have Dr. Sanjeev, who is the associate professor in the Department of Hematology at SGPJ Lucknow. We have Dr. Kishore Kumar, who is senior consultant hematology and oncology at BMT and BMT at Mayat International, Chennai. We have Dr. Meet Kumar, who is a consultant hematologist in Institute of Blood Disorders and BMT, Fortis Hospitals, New Delhi. Dr. Kanan Subramanian, who is a consultant hematologist in Pune. Dr. Sumit Mirg, who is assistant professor at the adult hematolymphoid and BMT unit in ACTRIC TMH, Bombay. And Dr. Ankit Jitani, who is consultant hematology and BMT and Apollo CBCC Cancer Center, Ahmedabad. Good evening to all the panelists, and I'll start the discussion today. So I'll skip these slides because I think most of this has already been covered in Professor Zeiss's presentation. So we all know that we have an overlap of acute and chronic GVHD, which is a defined acute GVHD within the ones that occur within the first 100 days and chronic after 100 days. There are different scoring systems, and I'm sure different institutions would follow each one of the following. So I'd come to Dr. Ankit first and ask him, what are the practical challenges that you face in the diagnosis of GVHD? So you can cover that in terms of clinical presentation. How do you go about the biopsies? How much do you rely on just the biochemical tests in the presentation? What imaging would you do, and if at all? And especially in gut GVHD, would you look for, what microbiological diagnosis would you look for associated with GVHD?
So in terms of clinical presentation, the main challenges are in terms of the regimen-related toxicities, followed by the infectious complication, mainly the viruses, CMV, adeno, and C. diff. These are the definite challenges we face. Apart from that, there are pharmacy which is going on. So skin GVH is always, drug associated differentials also come into the picture in terms of the clinical presentation in the skin picture. For biopsy, the threshold for biopsy in skin and gut GVHD is relatively low. We do take into consideration the biopsy for skin and gut GVHD, both upper and lower. For liver, definitely it's a challenge to obtain biopsies. Imaging, yes, again, ultrasound, the threshold for ultrasound is very, very low. It can pick up, it can rule out, for that matter, VODs in the initial part. What was the next point? Biomarkers.
No, so biochemical tests and clinical presentation, you've covered most of it. So do you order for microbiological tests from the stool whenever there is a suspicion of GVHD upfront? And if at all, what tests would you order?
So we do the microbiological test is mainly to rule out other possibilities. We do go for culture. We do rule out a C. diff, CMV, PCR, but definite microbiology mainly for to rule out other infections, ongoing infections.
Okay, and I'll also go to Dr. Sanjeev and ask him, would you do a biopsy in, how would you face a challenge in doing biopsy in almost all cases, especially for the skin and the gut? Liver, I do understand that's a challenge, but what's your approach to biopsying the skin and the liver when you, and the gut when you suspect GVHD?
Definitely, when we suspect gut GVHD, we consult with gastromedicine people and very low threshold for doing gut biopsy.
Okay, and would you go in and do a full scopy in all cases, or in patients who are sick, maybe, or you have a high index of suspicion, would you probably just do in with flex sigma?
Depending upon the situation, what is the presentation of patient? Sometimes we go for both, otherwise upper GI endoscopy mainly.
So I'd start off with a case, which is a 21-year-old male with AML intermediate risk in CR1, transplanted with a matched unrelated 10-on-10 donor, conditioning flu trio 14 with RATG, and GVHD prophylaxis being cyclosporin and methotrexate. The patient developed fever from day 7, has a Klebsiella MDRO AMC positive. It started on antibiotics from day 7. Fever settles down by day 9, but there is again fever coming back on day 14, which is low grade. You send the cultures, procal is 0.4, hemoglobin is 10, WBC is 300, platelet 10,000. Patient is otherwise hemodynamically stable, and by this time, when you suspect the patient is engrafting, the patient has a mild pruritic rash with generalized flushing, which by the next day has covered more than 50% body surface area and is itchy. And the patient is still febrile with the blood counts, as I've shown, about WBC of 500 and platelets of 12,000. So my question to Dr. Kishore would be, would you escalate antibiotics? Would you consider adding steroids? Any blood tests that you would like to order or follow? And would you order skin biopsies for this patient?
Dr. Kishore is not there.
Plus cytokine storm and should be treated with the steroid. So I would definitely start steroid without thinking with the 1 milligram per kilogram twice a day, 2 weeks, and then we'll follow. Not consider skin biopsy, not consider skin biopsy.
Okay.
We'll definitely look at the other sign and symptoms of hyperacute GVHD or peri-engraftment syndrome. It's like all the nomenclature has been given, and fever as well, skin rash, two criteria is sufficient to label this patient. This is more or less cytokine storm. I'm sure this patient must be on GCSF also. That is also adding a risk factor for hyperacute GVHD and peri-engraftment syndrome.
Yeah, which also brings us to a very interesting question that you raised. So would you add GCSF to all patients who are matched sibling or matched unrelated donor transplants?
Definitely in India, we do, because the problem is that like even 1 or 2 days delay in engraftment, and at the time of nadir of the leukopenia, they will develop MDR sepsis and they die. So we have to take a balanced approach. Give GCSF to everybody. It helps into rapid recovery of the count.
Madam is raised. You've raised your hand. You want to pitch in one? Ma'am, we can't hear you. You're muted.
This is a very, very crucial time where you have to judge between whether it is an engraftment syndrome or it's an infection, which already you have excluded by doing the procalcitonin, which is less than 0.5. So, or it is a GVHD. And as the disease is, it's a leukemic, it's a malignant disease. So possibly this is due to engraftment. That is the only thing. And as far as GCSF is concerned, it depends on the center to center. We don't prefer to give GCSF because it will aggravate the situation. And at the same time, GCSF causes, it's a decrease the cytotoxic effect of NK cell. If you want to achieve NK cell mediated graft versus leukemia effect in these kind of patients, so of course you have to take care of these, so which we generally avoid in these patients.
Sharad sir, you want to comment?
Yeah, Arijit, I just want to say something because I have exactly a similar patient currently in the unit post a haplotransplant. So this is coming on the back of trio also, you know. So for some time we had this situation where we're looking at skin pigmentation, little peeling, and you know, that's exactly what's happened. And as of today, we're in the same situation, a little bit of fever, count is about 300, 400. And we called in derm, okay, before giving the steroid, and they wanted to actually go and biopsy. Okay. And then we sat on it. I actually was pushing a small dose of Dexa rather than go the full dose on the methylpred. And then we pushed for an urgent biopsy, and it's come back as grade 2 skin GVHD. Okay. So you can go either way. And I still think there's a utility doing the biopsy. It's good to document some of these things, you know, rather than, we all know we would give the steroid, but you might as well get your tissue in and do it. That's why I thought I'll just bring in that point.
Thanks, sir. That point noted. Sumit, you want to comment? Raise your hand.
Yes, sir. In addition to Dr. Sharad Damodar's point, I would like to add that at this time point, yes, steroids, because he has a MASH undulate donor, a peripheral blood graft, myeloablative conditioning, counts are coming up, low-grade fever, you have ruled out possibly an infection with respect to negative cultures. Yes, we are going to give steroids. Those are not more than 1 milligram per kg, but I would also like to see.
So you say not more than 1. So you
not more than 1 in skin and upper gut, we give a low dose. I wanted to add that if we wanted to also do a chimerism at this time by VNTR to look at what the chimerism is, and if it's a full donor, then especially yes for skin GVHD and steroids. Skin biopsy, yes, always, even if it's a Sunday or a platelet count is low, that's not an issue.
Yeah, I put in the point. I didn't tell one it's a Sunday. Okay, great. So I go to the next point, which is the second case for 52-year-old gentleman with MDS EB2, having a matched sibling donor allogenic transplantation using flu 314 with cyclosporin methotrexate as the GVHD prophylaxis. The patient had grade 3 mucositis. Was on PPN and engrafting from day 14. On day 17, you find that the liver enzymes start climbing up, bilirubin 2.5, the transaminase is around 60 and 72, alkaline phosphatase and GGT disproportionately high. You're suspicious, you don't start anything, the viral markers are sent, it's negative. No skin or gut abnormality as such at all. So by the next day, the bilirubin has climbed to 4.5 with mostly direct, and so have the liver enzymes as well in terms of ALP. There is a mild weight gain of around 3 kgs. You've tried to keep it flush as much as possible, but still the balance is around 1.5 liters. There is mild liver tenderness, not gross. You've done a CBC which shows that the patient is engrafting. The blood counts are around 600, platelets are 36,000, monocytes are 34% coming up. So, and the abdominal ultrasound, you've done no macroscopic evidence of VOD, no reversal of the flow. So, and no ascites as such. So how would you, what differentials would you consider, and what additional tests would you like to order? Meet, sir, if you're there.
No, Meet is not there.
Okay, madam, you want to take this question?
Yeah, in this case, of course, you have excluded VOD, which is most commonly seen with a bilirubin of 4.5. So, of course, I'll go with steroid. I'll initiate steroid considering the liver GVHD, of course. So I don't think there is diarrhea to this patient. You have not mentioned.
No, there is no skin and gut, ma'am. So no skin or gut abnormality.
I'll start with the steroid of 2 milligram basically in the divided dose for the next 5 days.
Okay. Sunil sir, if you're there. So how often do you deal with patients who you suspect that TPN would be a causative, and what do you do with TPN in such cases where you have only cholestasis, apart from starting steroids as well? But would you probably stop the TPN in this patient? Also, sorry.
Yeah, I'll go with the TPN as well.
So you would continue the TPN?
Yes.
So Sunil sir, if you are there.
Yeah, I'm here. Sorry, I had a little trouble in logging in. If you could show me the case again.
Yeah, sorry.
Slide. Yeah, this one.
So it's
so I don't deal with adults, first of all, so I have to confess. So I may be a little vague, I would say. But having said that, I think, liver GVHD is the most difficult one to diagnose, I would say. Skin, it's easy. Gut, we have a easily available biopsy to correlate, but liver is the most difficult organ to diagnose. And if you see this case here, there's only cholestasis. The liver enzymes seem to be normal, and there can be various and varied reasons for having this cholestasis, and TPN is of course one of them, including some other medications which the patients must be on. So that also needs to be taken care of.
Yeah.
And the third important thing is also veno-occlusive disease. This is also setting for that. Ultrasound you mentioned is normal, but that may be normal in the initial phases of the veno-occlusive disease. Of course, GVHD, we're doing a GVHD session, and I'm pretty sure this patient must be having GVHD, but these are the other things which we always need to keep in mind when we diagnose liver GVHD. If there's a GVHD in any other organ, maybe skin or gut, then the diagnosis of liver GVHD is easier, and there's definitely set guidelines of how to diagnose the liver GVHD. That it's a long discussion on that, but I would suggest that we need to rule out the other aspects as well before we go on to labeling this as liver GVHD. And if other things are all right, then we probably can think of it and also start the treatment for liver GVHD. I would stop TPN initially, and wait for another 24-48 hours, and see other pharmacy which is going on along with. And then after ruling out other things, we will then start steroids for liver GVHD. A little bit different for liver.
Yeah, because I think the two most things that we usually consider would be TPN and CNIs, but CNIs you can't stop in this situation. So Sharat, say you want to come in with a point?
Yeah, I'm still thinking that we would be pushing for VOD here first rather than GVH. I'm uncomfortable with that ultrasound report. You've got a 1.5 liter positive balance. You've got features of cholestasis. And it's not that always you show up. It also depends on the skill of the person doing the ultrasound. So there are a lot of variables.
But then not always would you find that reversal. It's probably
correct. You may not always pick up the reversals. Absolutely. So we're still pushing VOD first, and then we would probably do that first. If you're really push the steroid. But my also question to everybody is, how many of us are actually pushing for that TJ liver biopsy? Because I've had trouble in the past, sort of experience, little jittery to go and push for that. You're still going with the clinical signs, symptoms, and making a diagnosis.
True, absolutely.
Dharma,
you want to come? Yeah. Yes, ma'am.
At this point, because it's early on in the transplant, what we are increasingly seeing, especially in patients who are on TPN, is Candida sepsis is also one of the differential diagnoses for just isolated hyperbilirubinemia. So it's always worth ruling out Candida sepsis, especially if there's TPN plus steroids. It can rapidly worsen the clinical condition. So I would carefully rule out Candida sepsis before giving the steroids.
So, there's so many factors going on here with azoles being there as prophylaxis, CNIs being there, TPNs being there. So it's always difficult. Dharma, you want to come in before I go to
I was just saying what Dr. Revati said, the drugs, azoles, TPN, the hepatosplenic candidiasis, and when you look at the 600 count and seeing the liver GVHD only, probably not seen that commonly. And if you look at these are not this graft. There's still no graft. Complete recovery, more than 5. You can't say it's engrafted. So and the criteria for, again, I'm going hyperacute GVHD, that peri-engraftment syndrome is different, and the VOD is part of that, or DAH, VOD, so many things. So I would definitely go, as Dr. Sarad and Revati said, probably will keep the VOD as a first possibility. And, in the Spicer criteria, if you look at the without graftment, the liver abnormality to label hyperacute GVHD is not that common.
True. So in the interest of time, I'll go to Sumit, and ask you, do you study or follow any biomarkers as in GVHD routinely or as part of clinical study? And if yes, what?
So with respect to biomarkers, we are only doing the stool calprotectin for gut GVHD patients. Routinely, not as a part of a clinical study, yes. But apart from that, no other biomarkers.
Okay. So I'll just quickly move ahead and go and touch briefly on GVHD prophylaxis. So as we all know, it differs from institution to institution with CNI-based regimens and PTCY-based regimens. And there is also the concept of ATG in mud, serotherapy in mud products. So, and there is some data coming up, promising data with PTCY-based regimens, even in matched sibling and matched unrelated donor transplant patients. So I would ask, I put the question to Sharad sir and ask, what's your approach in choosing the GVHD prophylaxis regimen? Would you stick to an institution-based protocol, or are you flexible modifying it based on the profile of the patient?
Yeah, I think we would put everything together there, Arijit. You would start with something which is institution-based protocol. You're going to then start looking at trying to individualize some of these things for that particular patient, whether there's been history of a renal issue, you've got something as a previous hepatotoxicity in the past. So putting all this together, and then whether you're actually, in a haplo, you're going PTCY, but we're also looking at it now even in the other settings. So all this put together, plus your intensity of your conditioning, are you bringing in ATG there? Is it coming in both for, as part of conditioning and also as GVH prophylaxis? So there are multiple issues. So I think most of us tend to individualize based on our patient profile and their prior chemotherapy and toxicities which they've encountered in choosing some of these drugs, because they do have, they do produce trouble down the line. So certainly a little bit of both.
Okay. Revati ma'am, I'd ask you, what's been your experience using PTCY, whether you've used it in non-haplo setting?
So thanks for the question, because every time we've done second transplants, we've in the fully matched siblings, so especially in TALs who've rejected, it has worked beautifully. So PTCY, I think, is a very good agent for both graft rejection and graft versus host disease. So when we've done a fully matched sibling, previous rejection, second transplant, we have a case series of about 11 now. So there it has been useful. Haven't yet picked up the courage to use it in routine transplants other than haplos. So not in the mud setting or in the sibling upfront transplant setting so far, but we are looking into it. Yeah.
Okay, I would go to Dr. Jaiswal and ask, have you had any experience of using sirolimus as a GVHD prophylaxis regimen? And would you consider ATG in the non-mud setting? Madam, if you could.
Yeah. Sirolimus, as far as sirolimus is concerned, we are using in non-malignant diseases because this is an mTOR inhibitor. It increases the Treg percentage. So it is more helpful in achieving the transplant tolerance rather than getting the graft versus leukemia effect. So the idea behind of using the sirolimus is to in non-malignant settings so that we can have more of the immune tolerance as thalassemia and non-sickle cell anemia or sideroblastic anemia.
Okay, so I'd go to the next question of what. So I think we've covered most of it, but I'll reinitiate the question on what schedule would you follow for tapering of the steroids, and what would your decision be influenced by the site of GVHD, the stage of GVHD, the age of patient, and comorbidities? And Dharma sir, if you could take this question.
So, the standard dose for GVHD, just 1 second. Yeah, so we start for wherever the applicable, the patient who need this treatment, not like a grade 1 skin GVHD alone. So wherever it's applicable, we start solimodol, methylprednisolone 1 milligram per kilogram twice a day and then assess the response. So and
how would you taper?
We give for 2 weeks full dose and then we start tapering. So usually that goes on an acute GVHD, clinically significant, the grid will be for 4 to 6 weeks.
Okay. Rajiv sir, I would ask a question to you. Would you add a non-absorbable steroid for all patients of gut GVHD, irrespective of whether it's upper or lower? So if you're there. So, Sumit, you want to take this question? Would you add
Yes.
budesonide?
We routinely add oral non-observable steroid budesonide 3 milligrams 3 times a day for all patients of gut GVHD. Especially for upper gut GVHD, it works very well. Wherein even in the absence of systemic steroids, only a non-observable steroid per se can lead to remission in majority of these patients.
It's quite interesting because actually it's not the data is not quite robust with upper gut, but it actually works quite well. So I would fully agree with you.
I just wanted to add that
Yes,
I
ma'am.
absolutely agree with him. And when we've used budesonide for in children, especially with the gut GVHD, the upper gut heals very quickly and they continue to have loose stools. So they're very hungry all the time, but whatever they eat, they can't digest. So you have to be careful and balance the use of budesonide and systemic. Use a combination of both so that neither of it are too toxic.
Point taken, ma'am. So I'll go to the next case. I'll be brief because I think in the interest of time we have to run through. So it's a child, a 10-year-old child, 20 kilos in weight, Philadelphia positive DALL, hasn't attained MRD negativity by the end of consolidation as well. Has got steroid myopathy by the end of induction, is recovering, barely able to walk, but otherwise well. Matt sibling, brother, flu TBI, conditioning plan, cyclosporin, methotrexate. So I won't go into the question of whether this patient should be taken up for transplant. So it's been transplanted and he's engrafted on day 16. And he's had loose stools of about 1.5 liters on day 20. C-diff is negative, sigmoidoscopy and biopsy is consistent with acute GVHD. Started in methylprednisone 2 mg per kg and responded by day 22. So specifically in this scenario, how would you like to taper? Would your approach be different in tapering? Madam, if you take this question before I go to Sunil sir.
So this is high-risk pH positive ALL, and you want them to get GVHD, but not so acutely and not so badly. So still, this is one child where I would consider adding Jakavi early so that we can come off steroids, considering the amount of steroid toxicity he's had. And offer again ECP early, because we have ECP at our center and early ECP will help them come off steroids quicker. So I think if he responds to Jakavi, then over a 2-week period, we would give the full 2 per kg steroids and then taper over the next 4 weeks. But if they're not responding to Jakavi, 2 weeks later, counsel the family regarding early ECP.
I go to Sunil sir and ask, sir, if this patient, whether when the methylprednisone is being tapered by the time we've reached 12 milligrams, the loose stools start worsening again, and the myopathy is worsening. The child is barely able to, is not able to stand at all right now. So would you again hike up the dose to full 2 mg per kg or go to a lower dose, and whether you'd add a second line agent as madam was suggesting? So Sunil sir, if you could take this question.
Yeah, so I think the catch here is the steroid myopathy, which is pretty significant. So if that wasn't the case, we would definitely treat for 2 weeks. And then think of taper. The taper here was pretty soon. It was in 1 week, but I can understand that maybe because the myopathy being the background, that was the decision which was taken. So I would have done exactly what ma'am suggested. That was that if we're trying to taper it early, we should have added a steroid sparing agent so that we could do the taper earlier on, and Jakavi would be a good steroid sparing agent. And if finances was a problem, then mycophenolate would have been another alternative agent to add on to have a steroid sparing agent. And of course, because it's a gut GVHD and we don't want systemic absorption, budesonide or a topical steroid would be a good choice to add along with, so that we are able to taper off the systemic steroids pretty quickly.
Okay, so we go on to steroid refractory GVHD. I won't go into the definitions, but starting dose would you consider?
Okay, so for a steroid refractory GVHD, obviously nowadays we are going towards Jakavi only, predominantly Jakavi as our first preference. And the starting dose in majority of the elderly or adult patients, if we can do is at a dose of 5 to 10, depending on the platelet count and how acutely you have seen this GVHD coming up. We will decide what exactly we need to do. And so we start at 5. If the platelet counts are high, maybe even start at 10 milligrams based on that. And for some patients, obviously the platelets are very low. You would end up actually starting lower, but preferably start from 5 and then either go up or come down based on what we see and how the response to your GVHD was. The second line agent, it all depends upon, for many of these patients actually, they will be on other drugs many times, say like mycophenolate and steroids. The steroid we would prefer to taper off much faster while continuing the Jakavi at full dose. And we also try to come off, say, mycophenolate if that is on and come down. And coming to the choice of drug influenced by the site of GVHD, I think, I mean, even for GI GVHDs, you would still end up giving Jakavi. No major problems with the absorption until unless it is, say, grade 4 and you're seeing Malina and things like that. You could still go ahead and give oral Jakavi if there is no other problem.
Okay, so I think my apologies if Robert Zaisa is with us. So Dr. Zaisa, I would like to ask your question on. So would blood counts influence your decision to choose your second line agent, or would you be happy doing ruxolitinib for everybody? For example, if there's an isolated lower gut GVHD, would you consider other agents, maybe only ECP or vedolizumab? And how do you place your how do you choose your agent?
So, Dr. Adijit, you know that we are using a very specific molecule, which is called T-cell co-stimulatory blockade in our protocol. So, hardly we see any GVHD in terms of less than 10%. If you talk me about the incidence, are very less. So, less than 10%. And whatever you use, so has the same result, and at the same time ruxolitinib has also the similar kind of result. So it's a very dicey situation, but of course in that situation we use abatacept, Jakavi, and IL-2 inhibitor, or it's a basiliximab also sometimes we use. So this is the thing.
Okay, I'll ask Dr. Zaisa if you're there. Sir, how would you choose your which agent to give, or would you use ruxolitinib in all patients? Okay, so if you're there, okay, so I would go on to the next question. I think this question was asked, Sumit asked this question. So what would you do with the steroid dose in steroid refractory acute GVHD? I know there are different opinions. So would you like to taper off and stop fast, or would you like to persist with the steroids? Maybe something is better than nothing. So, Sharad sir, if you could come in.
Yeah, so we wouldn't abruptly take it off, Rajit. You would certainly drop the dose to closer to 1 per kg and keep it on for a little longer, because there's data that, I mean, some people do advise taking it off faster, but then you're really not sure that your second agent has started working. Even if you've introduced Jakavi or used one of the other injectables, etanercept, basiliximab, you could do whatever you want. You still need some time for bridging. So thereby, most of the time, from a practical perspective, we would try to drop it, but keep it at that 1 per kg at least, and not totally take it off.
Okay. Dharma sir, if you share the same thought.
Yeah, same thought. Like the steroid has to be one of the part of the backbone of the GVHD protocol. Whether you add second line, third line, yes, not 2, but with 1 milligram or till complete response, then you will start tapering.
Okay, Sumit, you have seen? Okay, would that be your same practice?
So we are a bit skeptical with steroids. We bring it down to 0.5 a bit rapidly, but and keep at that point for some time point until the patient achieves a response with the steroid sparing agent. Our usual steroid sparing agent is etanercept, because that has been the experience before ruxolitinib came into picture, and it was very expensive. And it has led to.
So if it's 2 weeks, 3 weeks with etanercept, it's still not working, still lose 2. Would you still keep the steroids going?
Yes, we keep the steroids ongoing, but as far as it comes to 1, and then we cut it down to 0.5. At 0.5 and beyond, we are a bit slow, but before that, it's okay. We keep on the steroids for some period of time.
Okay. And at what point, so the question is, if the patient is on ruxolitinib, at what point would you say, no, probably the drug isn't working, I need to add the third agent here? So Sunil sir, if you could take the question. So what point would you say?
First of all, just little thought on the previous talk, and also continuation here is that the most important thing in a steroids refractory GVHD, especially the gut, is to holding the nerve. So we lose more patients to immunosuppression than to the GVHD. So I think adding second line, third line, fourth line is something which has to be done carefully and slowly. We know that GVHD progresses pretty fast, but the recovery is pretty slow. So that's one of the things I would like to practice, and something which I have learned, I think, over the years, burning our hands. Now on the third line agent, so if we have used Rux as a second line agent, and we have started reducing steroid slowly and added a second line agent, which is Rux, we need to give it substantials and enough time for it to action. And I wouldn't expect anything before a week. So there will be I don't think there's been much response which would be seen within a week's time. So that's why we need to support this patient during that time with various other supportive care measures. And I would only think of adding a third line agent after 2 to 3 weeks of adequate dose of Rux. And if after 2 to 3 weeks we don't see a response, then we can think of changing it to a third line agent.
Okay. Yeah, so persistence would be the key, at least 2 weeks. So I think this is another question that probably has been asked. So what dose of ruxolitinib would you start with in adults? Ankit, if you could take this question. So if you start ruxolitinib, what dose would you start with? Especially considering these patients are also cytopenic. Most of them are cytopenic at this time. So what dose would you start?
So even if the patient is cytopenic, we have seen that 10 is pretty low dose, but still there is skepticism, and we do start at 5 twice a day and gradually escalate to 10 maybe in the next 3 days or so, based on the tolerance and the count. So that is what we do. We start at 5 and then escalate to 10.
Okay. Sharad sir, what would be your practice?
Yes, would agree, Arijit. 5 BD is what we would start, and then try and see whether we can bump it up to 10. There's this little bit of enzyme elevation. Sometimes you see, then you start worrying, is it GVH? Is it the drug? Again, the little drop in counts. So a little big mixture of all of them, but starting 5 BD, and then like Sunil was saying, you would wait at least 2 weeks before you kind of say that you're refractory to second drug.
Okay. Yeah.
But in the bargain, if you have somebody with grade 3, grade 4 gut, your tendency is to kind of look at the third drug a little earlier. No, yeah. I mean, I'm just telling you practically. That's why.
Yeah. So 2 liters, 3 liters,
yeah.
7 days, 15 days. It's like difficult. But so I'd come into Devati ma'am and ask, ma'am, what has been your experience of using ruxolitinib in children, and what dose would you consider in children?
Ma'am is left for some.
Okay, so if you could take the question, yes.
Yeah, we do use, of course, it has been off-label use. There are, we have been enrolling on REACH 5, but that's a chronic GVHD. On acute GVHD, it's still off-label use. And but there's a large experience. I think more than 50 children, we have used it as a second-line agent. I feel that the experience has been good. But there are two things which I, would like to highlight. One is that I've seen that it should be used early than later. So, sometimes when we used, especially in the earlier experience when it was not readily available, we used to as a burnout agent, everything else has been used. And then you introduce Rux. We haven't seen good results there. But recently, when you has used more early and as an immediate second line agent, the results have been pretty decent. Second is that persistence of giving adequate doses, of course, and also persistence of the drug for enough time is important. And also when we stop it, it has to be slow taper. That is something which is important in our pediatric practice also. I think the doses you mentioned here, we use for more than 40 kilos or children with more than 12, same adult dose as 10 milligram BD. And the younger children less than 12, we use 5 milligram BD. Now, I little differ with what was said earlier that, if there is no contraindication, and that contraindication, especially is hepatotoxicity or severe neutropenia, at the start of the drug, should start with the adequate dosage, which is 10 milligram BD in adults, and of course, whatever is the pediatric dosage. And because the cytopenias, especially when not started the drug also, is multifactorial, and it may be GVHD itself, drug induced, and various other factors. So I think the mantra is to strike it adequately with the adequate dose to begin with, and of course adjust later on if required based on the cytopenias.
Yeah. So which brings us to the next question: how would you adjust or taper the ruxolitinib dosages? And I go to Sumit, if you could take this question.
Right. So as far as the platelet is more than 10,000, we are not worried. Once it comes down to less than 10,000 the platelet count, we decrease the dose to 5 mg twice a day, but we have never stopped that abruptly if there is severe cytopenias. For neutropenia, I've supported with GCSF. And if it is less than, say, 500 for a long time, then we decrease the dose. Otherwise, it's really not an issue. If we see that,
and would your threshold of giving platelets be more, higher if you consider that you're giving ruxolitinib in this patient who's got, say, maybe 15,000 platelets?
So
would
if
you
the patient is not
augment it
bleeding through the gut, then it's okay. But as far as it is more than 10,000, the patient is not bleeding, it's fine. Only at the count of 15,000, I would not give the platelet transfer if the patient is solid.
Okay. So I go to what has been your experience in managing infections while treating the patient on ruxolitinib. So I'd go to Dharma sir, if you are there, if you could take this question, and what infection profile, if anything, different that you would have found in your patients who are on ruxolitinib?
Honestly speaking, I have not noticed too many viral infections. So the CMV is concurrent problem because of the Rux, steroid, and everything. But beyond that, very rarely we've seen rhinovirus, cystitis, but no experience about EBV and other.
Yes, and also
this question that the Indian population, they are prone for tuberculosis reactivation. So every time, if there's any symptoms, one should keep the eye on the tuberculosis.
Yeah. So if in a patient who's had a previous history of tuberculosis, would you be brave enough to initiate ruxolitinib in the patient?
Absolutely. The leukemia is more the killer than the tuberculosis. We have to do transplant. We have to treat them, and whatever it comes, we have to keep an eye about the reactivation of tuberculosis.
Okay, because I think the observation that's become from trials is that the incidence hasn't been different, but still the viral infections would be a problem. Sunil sir, would you agree with?
Yeah, no, I agree. See, I think this is the best of the lot, I would say. So any drug which is used for GVHD is of course going to be immunosuppressive and is going to increase infection risk, both of reactivations as well as primary infections. And their morbidity, of course. But out of the lot, which we have been using traditionally as second-line agents, like etanercept, basilisumab, including ATG sometimes, this has a better infection, I would say, profile than the others. You would see reactivations, and from the trial point of view, they have to report all these events, and they have been reported. But if you look at these papers which have been published, especially from the REACH series, they don't seem to be significantly higher than the control group. So yes, viral reactions are going to be a problem, but they will be probably better off than other second-line agents.
So have you been able to use ruxolitinib in the children who aren't able to take tablets, and would you, like, what would you do for those patients?
So I know there hasn't been a great study of using Rux through NG tubes as crushed formulations. They haven't been. PK studies from the REACH studies, they have used syrup format as well as tablet format, and there are PKs on that, but not in the crushed format. But it is a practical problem, and we don't have syrups available yet in India. So we use crushed format, and I don't have any data to say that yes, it's getting absorbed and we get, but we have seen responses. So that indirectly may tell us that it's probably okay to do that. And there is some data in smaller studies where they have used as crushed formulate, and they have seen that it's pretty good, okay to use. But I think syrup would be a good addition to the formulations. I think they should get it as soon as possible in India. As I said, we enroll a REACH 5 study. Their syrups is available for younger children, but that's part of the trial, not commercially available yet.
Okay.
Rijit, you're out of time.
Yeah. So so I'll finish. Thanks. I just skipped the last question. Yeah. Thanks.
Thank you so much,
Thank you.
and the panelists, and also thanks to Dr. Robert Zisa for his lovely lecture. I'll just share my screen. We now move on to the panel discussion on Altrembo-PAG and severe aplastic anemia in 2022. Moderator is Dr. Radhika KK. She is MD DM Clinical Hematology, Associate Professor, Department of Clinical Hematology, Nizam Institute, Hyderabad. Panelists include some very important persons. We have Lieutenant Colonel Dr. Ashok Meshram from INHS Aswini, Mumbai. Dr. Ashutosh Panigrahi from eACE, Bhubaneswar. Dr. Avinash Singh from Paras HMRI, Patna. Lieutenant Colonel Kundan Mishra from RNR, New Delhi. Dr. Mukul Agarwal from eACE, New Delhi. Dr. Pawan Kumar Singh from Artemis, Gurugram. Dr. Punit Jain from Apollo, Navi Mumbai. Dr. Rahul Arora from HCG, NCHRI Cancer Center, Nagpur. Dr. Salim Mirza from Chandi Mandir. Dr. Upendra Sharma from Bhagwan Mahavir Cancer Hospital, Jaipur. So we can begin with the panel discussion.
Thank you, sir. Thank you, Mumbai Hematology Group, for this great opportunity. It's a pleasure to be moderating this session with great experts in this area. I shall share my screen, sir.
Yes.
Sorry, sir. Is my screen visible, sir?
Yes.
It got stuck up.
You can stop and again share the screen.
My mouse got stuck up, sir. Mr. Kalpesh, can you run my slide deck? Into the slide deck mode. Yeah, sure. Thank you, sir. Thank you, Mumbai Hematology Group, for this great opportunity. I'm Dr. Radhika from Nizam Institute. So it's a pleasure to be moderating the session with the great panelists here. Sir has already introduced everyone. So the next half an hour, I'm going to discuss 4 of my cases which I've encountered in my regular practice. So without wasting much time, going to the case number 1, So here is a 33 years old male, no comorbidities, January 2022, presented with ecchymosis, easy bruisability of 1 month duration, evaluated and managed elsewhere, CBP 7.7 HP, 5,000 with a low ANC count, platelets 10,000. He was diagnosed as an ITP elsewhere, managed with 4 doses of methylprednisolone, no response, bone marrow hypocellular with 60% small lymphoid cells. Somebody is seeing 60% small lymphoid cells on a bone marrow, went ahead with PET CT scan, which showed a metabolically active multiple skeletal lesions with subtle sclerosis to rule out primary skeletal lymphoma, remote possibility of IgG-RD. The marrow biopsy came out as hypoplastic marrow with lymphoplasmacytic infiltrate. Because the PET CT was showing some suspicion of a primary skeletal lymphoma or an IgG-RD, a biopsy from D11 left pedicle was done, which showed normal hematopoietic tissue, and there were no abnormal cells. That's when he was referred to NIMS hematology. I would like to check with Dr. Ashok. How do you go about with such a case when it comes to you in your practice?
Radhika Ashok is not there.
Okay, sir. So the next, Dr. Ashutosh, can I check with you? How do we go about with this kind of case? How do you evaluate this case? How do you substantiate this kind of finding on a PET CT scan?
Thank you. Thank you for, I'll thank Dr. Agarwal and MHG for this scientific session. So here it is though initially it is a bicytopenia, but we'll...
Ashutosh, slightly loudly, closer to the mic.
Yes, sir. Am I audible now?
Yes, much better.
Yes. Okay. So this is a young patient with bicytopenia, and we have excluded mostly the malignant part. So I'll definitely first consider whether I'm dealing with a hypoplasia, means aplastic anemia. So for that, it is already bone marrow has been done. So we have to review this bone marrow. We have to review this bone marrow for confirmation of the diagnosis, and simultaneously I'll prefer to go ahead with genetic testing to exclude other associated conditions, because here lymphoplasmacytic infiltrate is there. So I have to exclude other malignancies, hematolymphoid malignancies, at least clonal myeloproliferation. And next, because it is a young patient, I will do a detailed clinical examination whether it is pointing towards any bone marrow failure syndrome. Accordingly, I will approach for evaluation for the inherited marrow failure syndromes. So I will go ahead with a detailed clinical examination, then bone marrow cytogenetics, then this is stress cytogenetics to rule out Fanconi, and of course, it is a young patient. If clinical scenario permits, then I will go ahead with immunological workup like ANA, dsDNA to rule out any acquired conditions. And simultaneously, if history also suggestive, B12 folate estimation, though in many guidelines, it is recommended to go ahead with B12 folate estimation. So I will do that one also. So this will be the first approach for this patient, and what we do regularly in aplastic anemia patients.
Thank you, sir. Do you want to react to that PET CT scan report?
No, already it has been dealt, and it is not a significant finding. So I'll rather put a close observation whether it is going towards any clonal proliferation, but I'll not give importance to this at this point of time.
Yeah, sure. So there is a literature which shows that PET CT scan in aplastic anemia can show a picture like this. There are a few cohort of people who can show hypometabolism complicated with some patches of hyperproliferation. So this CT scan can be seen in cases of aplastic anemias. Next slide, please. So as you said, sir, we went ahead with a re-evaluation here with in our institution. So hemogram was showing pancytopenia, though the TLC was 5,000, ANC was just 350. Biochemistry was normal, nutritional profile was within normal limits. ANA was positive, but other autoimmune markers were negative. Viral serology, ultrasound, chest X-ray, all were normal. Next slide, please. So we reviewed the bone marrow aspiration and biopsy, which showed 20% cellularity, hypoplastic marrow with a lymphoplasmatic infiltrate. Because somebody raised a suspicion of a skeletal lymphoma and all, we went ahead with IHC on the lymphoid population, which was polyclonal. PNH was positive, stress was negative, HLA, one sibling was half matched, the other sibling was not willing to give. The diagnosis of acquired severe aplastic anemia was made in this case of a 35 years old male. Next slide, please. So, sir, again a question to you, Dr. Ashutosh. Do you consider upfront bone marrow cytogenetics and an NGS for bone marrow failure syndrome in all your cases?
I do definitely bone marrow cytogenetics for all my cases. Particularly for this case, I will definitely do a stress cytogenetics at least. And if it is clinically backed off, then only I will go ahead with a stress cytogenetics. And for NGS for BMF syndrome, basically there are two issues. One is affordability. If it is possible, then we go ahead with that. And if there is strong clinical suspicion. And second thing, baseline NGS BMF I do not do in all my patients. Only in significant population, selected population, we do it. But obviously, I do a baseline cytogenetics and stress cytogenetics for all those who are less than 40 years of age.
Okay, sure. So, any of the panelists do NGS routinely upfront in a bone marrow failure cases?
Can I add?
Yeah, sure. Yeah, sure. Thank
you. So, sometimes what happens when we send the stress cytogenetics, it is difficult to get the result. So because of low TLC, we get multiple times that it's not growing. And we are waiting for bone marrow transplant. So suppose patient has HLMS siblings, then sometimes these are the indications where we have to do NGS to rule out Fanconi anemia or something like that. Otherwise, I don't do routinely NGS in these cases.
Yes, sir. In my practice, I routinely do NGS for all people less than 20 years, unless until the patient is very much financially compromised. Less than 20 years, I do not compromise in a diagnosis, and we routinely go ahead with NGS along with stress cytogenetics. Don't want to miss out any other congenital BMFs. Okay, sir. Going to the next question. To Dr. Avinash, do you routinely do PNH profile in all the patients? And does a PNH clone size influence your management? If you find a significant PNH clone, more than 10%, do you consider low-dose steroid to the ACE regimen?
Yes. So I do routinely this one PNH profile, and this has some significance. One, when it's positive, then it gives me some confidence that I'm dealing with acquired aplastic anemia. Yeah. First thing. Second is, most of the patient I have seen clone size of very low size, so it's not so around 9%, 10% like that. So very rarely classical aplastic anemia, acquired aplastic anemia will have this significant of 50-60% of clone size. Mm-hmm. And young patients, I always counsel them for transplant if there is PNH clone is there. And if suppose BMT is not an option, then obviously we use triple combination. And I don't use steroid. If just to prevent serum sickness, 2 weeks of a steroid with taper is there, that is fixed. Otherwise, if there is no significant hemolysis or some problem, then I don't add steroid in the triple regimen, ACE regimen.
Yeah, great, sir. Even we don't add steroid, but some controversial cases where I see hemolysis, probably I add a low dose of steroid. And thank you.
Can I ask one question? So yeah, sure. Your case had this ANA positivity 2+. Yeah. Yeah. So what significance do you give to this patient with this ANA?
I do not consider any significance of a mere ANA positivity. The patient does not have any other clinical or biochemical criteria fitting for an SLE. Just a mere ANA positivity, I do encounter in good number of hematological cases. A mere biochemical ANA positivity, I don't really consider this as a significant factor to influence my management. Positive. I do see in ITP, I do see in ANAs.
So do you think this is a coincidental finding in this case?
Yeah, probably we don't need to do an ANA if the patient does not present with the clinical features of SLE.
But your patient had ANA positive from outside.
Yes, sir. So whenever I see ANA positivity in my patients, I dig down further and explore other markers of autoimmunity. Some 2-3 markers are positive, ACL antibodies, anti-Smith antibodies, 2-3 markers are positive, probably then I may consider an impending or an incomplete lupus. But the biochemical positivity of the markers does not influence my management. He has to fit into the criteria of an SLE, the 4 out of 11 or 5 out of 11, whatever. Going to the next question. Next slide, please.
Can I just add a comment?
Yeah, sure, please.
Regarding NGS in steroid, we recently encountered a 4-year-old child who was referred to as an aplastic anemia. We sent the NGS profile. It came out to be as a GDD, and patient really responded very well to steroids. So NGS really helps in patients less than 20 years of age, and it can sometimes be really give us therapeutic advances. Also, another patient who had aplastic anemia, 10/10 match sibling, NGS was done for the patient. Patient turned out to be RPS 24 positive. Even the donor turned out to be RPS 24 positive. Yes. And we had to refute the transplant in view of NGS findings.
At times, the NGS can be a game changer, especially in less than 20 years, because they look absolutely like normal, like an acquired aplastic anemia, but you find out some congenital abnormality in the NGS, and then that becomes a game changer. So I routinely do NGS for all the patients less than 20 years, unless and until I'm dealing with a very extremely financially compromised patient. So coming to the PNH, yes, we do PNH routinely, sir, because there's a paper by Dr. Philip Schoenberg. He says that the PNH does determine the prognosis of the patient. However, no specific measures needs to be taken if the PNH clone is silent. Next. So what are the treatment options you consider for this kind of cases? Dr. Kundan Mishra.
Kundan is not there.
The next panelist, anybody can take this question, sir.
I think I can take this. So since this patient is not having HLMR sibling donor, so the obvious choice at his age will be to go for a ATG-based therapy. Given the current evidence, it will be a triple drug regime with ATG for 4 days at 40 milligram per kg per day with cyclosporin and eltrombopag. That would be my go-to regime at this stage in this patient.
Yes, sure. So that's the routine practice.
Yeah, the only thing is that if the patient wants to opt for a mud transplant, that could be an option which can be discussed.
33 years upfront mud you want to consider here?
That is one of the options we can discuss. Yes.
Next slide, please. So as Sir said, we had these 3 options. Obviously, the best was the hematopoietic stem cell transplant, which was not the option in this case. So we opted for eACE therapy, as Sir has clearly mentioned. Next slide, please. Next slide. Next slide. Yeah. So ATG ACE therapy, ATG at 40 mg per kg for 4 days, cyclosporin 5 mg BD, and eltrombopag. We initiate the patient at 150 mg dose. Next slide, please. Next slide. We got a beautiful response at the 2nd month of ACE therapy in this patient. Next slide. So Dr. Mukul Agrawal, a question for you. Do you consider this is a question for you. Do you consider prophylactic antibiotics during ATG therapy? What is the dose and duration of eltrombopag and cyclosporin? And what is the response in your experience to ACE therapy?
We'll start with the first questions. Antibiotic prophylaxis. Routinely antibiotic, no. Antiviral acyclovir at least for the first 1 month. Antifungal preferably for the first 1 month, and ceftriaxone for the first 1 month. So at least that is the time when the patient are on steroids or on tapering doses of steroids, or may have an increased incidence of syringe sickness, and at which you may have to increase the steroids again. Duration of eltrombopag, 6 months. We are stopping abruptly in most of the patients, unless the patient has kind of a borderline responses. If the patient has a robust response, we stop. If the patient does not have any response, we stop. If he has a borderline kind of a response, then there is a case to continue eltrombopag for some time. Cyclosporin we are continuing for up to around 2 years and then tapering off slowly. So the tapering goes on for almost a year. The response rate with this regime in our experience have not been to the mark of Dr. Young's paper. What we've seen is that they're slightly better than the ATG plus cyclosporin regime. So it's around 70% to 75% overall response rate. The CR rates are somewhere around 20%. Most of the are partial responses. That's our experience.
Great, sir. So what is the dose of eltrombopag you start off with?
We are uniformly using 150 milligram in all adult patients.
150, sure, great. So that is what is our practice too. 150 mg we start with. We have a small data which are published with ACE regimen, which showed a response rate of 81%, an overall response rate. Next slide. So this is the literature, everyone knows. I'm not going to go through this. Next slide, please. Next slide. Next slide. So this NIH paper, which showed a 94% robust overall response. That was like a great, like a significant response, equivalent to BMT. Next slide, please. Next slide. So this is our response, wherein with the ACE regimen, we got around 81% response rate, of which the complete response is 25%. Next slide. So day 14, the patient had fever, rash, joint pains, ATG-induced serum sickness, managed with hydrocortisone tramadol. Day 18, discharged in a stable condition. And by second month, his counts have improved decently. He has achieved a partial remission. Next slide, please. Next slide. Yeah, by second month, he had a response. The plan was to continue eltrombopag for 6 months and cyclosporine for 2 years at a full dose. Next slide. A question to Dr. Pawan. So, April 2022, approximately after 2 months of ACE therapy, the patient has achieved a partial remission. Now we developed deranged liver enzymes, SGO2 735 and SGPT 1136. HbS-AG was positive and HPV DNA showed a high viral load of 17 lakhs copies per ml. MD consultation taken, he was initiated on entecavir. How do you manage this type of case? What is your consideration regarding continuation of cyclosporine and eltrombopag in this particular case?
Yeah, Dr. Radhika. So first thing is that the question of HbS-AG being positive and HBV DNA copy number very high. I remember this case previously before starting ATG, viral markers were done and HbS-AG was negative, I believe. Yeah. So we should actually as a routine practice also, we are doing core antibody also for our patient before starting on ATG. Yeah. So core antibody should have been done. Because obviously, if core antibody and this was done, then the HbS-AG earlier was negative. So he must have acquired this infection after, probably because of blood transfusion. Or so anyway, that's a different issue. Sure. But now, how to manage this patient? So obviously, with gastroenterology consultation, entecavir started, which is good. So I would also continue with the entecavir. And temporarily, I would like to stop both cyclosporine and Revolade at this point of time and watch for liver enzymes.
Achieved remission. He just achieved remission. I mean,
yeah, but still temporarily we need to stop it. I would like to stop it. Watch for closely watch for liver enzymes, and once it is coming down, then we can restart. This is what I would do.
Any other opinions from other panelists? What is your call on eltrombopag continuation and cyclosporine?
So Dr. Radhika, for this patient, yes, Revolade has to be stopped because the enzymes are elevated. Patient will end up into hepatic decompensation, and that will be troublesome for the patient. But I think we can continue with cyclosporine because it doesn't have much effect on the liver, and they're not that much immunosuppressive. So we can continue with cyclosporine. We can decrease some dose of cyclosporine, but we have to continue with some medicine. Yes, Revolade has to be stopped. Dose cyclosporine has to be continued.
Yeah. Great. Next slide, please. Yeah, there is some literature which says that cyclosporine or immunosuppressive therapy is safe in liver damage. IST does not lead to liver damage or fulminant HBV infection. So it can be safely continued in patients with active hepatitis infection. So there is some literature which I have gone through, and then they say that cyclosporine can be continued in active hepatitis infection. Next slide, please. However, Revolade needs to be stopped. Here is a case number 2. Move on to case number 2. 53 years male, known diabetic for 7 years. April 2020, diagnosed severe acquired aplastic anemia, PNH clone positive, 4.6, 2,900, 23% neutrophils, 10K platelets. Initiated on cyclosporine 5 mg per kg in 2 divided doses. Developed cyclosporine-induced renal dysfunction, creatinine shoot up from 0.8 to 2.5. Cyclosporine was withheld. Still, creatinine resolved partially but persisted at 1.5 to 2. Nephrology consultation taken, advised conservative management. So cyclosporine-induced nephropathy, a severe acquired aplastic anemia, 53 years male. What treatment would you consider? Dr. Puneet.
Puneet is not.
Puneet is not. Sorry, sir. The next panelist, whoever, any panelist can take over this question, sir. Elderly man, diabetes, cyclosporine-induced nephropathy. A bridging dose of cyclosporine has been given. What is the definitive therapy you would like to consider here?
So, Dr. Radhika, for this patient, yes, cyclosporine is causing problems. So we can continue. We can give this patient combination of ATG and Ruvalate. I will prefer a full dose of ATG, 40 milligram per kg for 4 days, and Ruvalate to be started day 1 with 150. Continue Ruvalate for 6 months, and then accordingly see the response. And if this response is robust, we stop Ruvalate. Else, if it is say, partial response, we continue for some time with Ruvalate.
Do you want to replace cyclosporine with any other drug, alternative drug, danazol, anything?
So literature doesn't support evidence for any other immunosuppressive medicine. We can combine other medicine, but the overall response rate has not been much of benefit. There can be side effect with those medicines, but giving say micromorphitel, sirolimus is not a good option for such patients.
In our Indian scenario, we commonly use danazol, right? Good number of people do use danazol.
So, yes, danazol can be used for this patient, but we have to be very cautious. Our main intention is to give Ruvalate. We have to continue with the Ruvalate. If say there is, we can combine danazol, which if there is derangement with the liver enzymes, then our preference is to continue with Ruvalate and stop danazol.
Fine. Yes. Thank you. The next slide, please. So, next slide. So we started him, we considered him for eltrombopag, danazol, and ATG. In view of limited finances, we had to go for a low-dose ATG here, 15 mg per kg per day for 5 days. Dr. Rahul Arora and Dr. Salim, so I would like to check with you your experience on low-dose ATG, conditions where you consider it. So have you ever considered a low-dose ATG in your practice?
Yes, Dr. Radhika, we have considered low-dose ATG in elderly patients, and when the finances have been limited, and low-dose ATG do work, and it gives similar response rate to the routine dose ATG. And when cyclosporine is contraindicated, as Dr. Upendra Sharma sir has said, the opinion has been very dicey with MMF and tacrolimus as well. So the response, the addition could be tacrolimus or MMF, but it has to be an individualized decision. And low-dose ATG does have a very good response rate.
Yeah, sure, great, sir. I do consider danazol in place of cyclosporine when cyclosporine is contraindicated. If we have a patient with enough finances to give either a full dose ATG plus cyclosporine or a low dose ATG plus eltrombopag plus cyclosporine, what is your preferred option? The finances are enough, just sufficient only for one kind of therapy, a full dose ATG plus cyclosporine or a low dose ATG plus eltrombopag plus cyclosporine. So what would you choose if you had these two options and you got to choose one? Dr. Salim or Dr. Rahul Arora, anyone?
Is not
Ma'am, we'll go with low dose ATG, eltrombopag and cyclosporine instead of a full dose ATG plus CSA.
Yeah. So, what is the rationale behind? I mean, why do you want to? Yeah, even in my practice,
the infection rates are little on a lower side.
Yeah, even in my practice, if I had these two options, patient had finances just for one, I prefer low dose ATG plus eltrombopag plus cyclosporine, because eltrombopag in my practice I have seen showing revolutionary improvement in the response rates. Next slide, please.
Yeah, same here.
So whatever the dose of ATG, I would like to add on. I would like to see an eltrombopag in those patients. So we have good amount of literature which shows that low dose ATG shows equivalent response rate to that of the standard dose. Next slide, please. Another paper showing that equivalent response rates with low dose ATG and the regular dose. Next slide, please. And there are a good number of papers which shows that danazol shows a good response rate and a preferred drug in case of aplastic anemia. It increases the T regulatory cells and hence shows a response rate. Next slide. Next slide, please. So this patient, we have given low dose ATG plus danazol plus eltrombopag. He achieved partial remission. He was transfusion independent by 1 month. He was continued on eltrombopag, 150 and danazol TID. He developed some hyperbilirubinemia for which no intervention was done. Dr. Salim Mirza, I would like to check with you what kind of side effects you commonly encounter with eltrombopag, and at what level of hepatic derangement do you consider withdrawal of the drug?
Salim is not there.
Yes, next, Dr. Mukul, you can take over this question.
So with eltrombopag, what we have encountered most commonly is transaminitis. Nothing else, other major side effect has been seen. And if the transaminitis goes beyond 5 times the upper limit of normal, we hold it for a week, call the patient after a week. If it starts resolving, we reinitiate it. So we don't hold off or stop the drug completely.
So you have a cutoff of 5 times the upper limit of an AS.
Usually above 5 times, we hold for a week and call the patient after a week.
So till then, you do not consider any drug dosage.
No. Just add ursodeoxycholic acid in that time period. That's it.
Perfect. Next slide, please. Next slide. So we have a drug insert which says that eltrombopag should be discontinued if the ALT level increases to more than 3 times the upper normal limit or more than 3 times the baseline, or there's a progressive increase in transaminase, or it's persistent for 4 weeks, or accompanied by increased direct bilirubin or clinical symptoms of liver injury. So these are indications wherein we withhold the eltrombopag. Otherwise, just for mild elevations, we do continue with the dose. Probably we decrease the dose, but we do not stop the drug. Next slide, please. So 6 months later, eltrombopag was tapered, danazol continued on. Then eltrombopag stopped, but danazol was continued. So I would like to check, Dr. Upendra sir, do you consider taping of eltrombopag at the end of 6 months?
So previously Dr. Mukul has given the answer for this question. So for those patients who have good, robust response, we abruptly stop eltrombopag after 6 months. For those patients who are having partial response, we continue for some more time with folate. And so duration is usually 6 months for our patient, and accordingly we have to see the response rate, partial response for a few weeks more.
Perfect, sir. So in this patient, I continued for 6 months, tapered over the next 3 months. I stopped by 9 months. So the moment I stopped, my count started dropping down. So what do I do next? So 9 months of eltrombopag, my counts now started dropping down.
So this happens for most of our patients. They're having partial response. Once you stop with your immunosuppression, these patients tend to have relapse. So patient has responded to this or immunosuppressive medicines. We'll restart with Rivolate and cyclosporine, then do a slow taper for these agents, see the response, and do slow tapering of this.
Great, sir.
And Dr. Radhika, for my patients who are having no financial issue, the robust data is for full dose of ATG. So for most of our patients, our preference is to give full dose of ATG 40 milligram per kg for 4 days, not low dose. For those patients who are compromised financially, those patients or elderly patients more than 70 years, we go with low dose ATG, else we go with full dose of ATG.
So you would like to compromise eltrombopag for a high dose ATG standard?
So no, finances are not an issue. So for those patients where the finance is not an issue, we'll give full dose of ATG, full dose of Rivolate, full dose of cyclosporine, no compromise with the treatment. For those patients, finances are an issue. Yes, we can see, and we have some paper wherein low dose ATG has done work, but we have more robust data for full dose of ATG. So for this is a one chance for most of our patients. Transplant is not up to reach for most of our patients. So we want to give best treatment for our patient. So I don't think so we should compromise with the, because we have limited literature of the low dose of ATG.
I agree with you, sir. Even I
And can I ask one question?
Yeah, please.
So low dose, you use half of ATG, full dose?
So
15
milligram per kg for.
So I'm just asking that full dose of ATG plus cyclosporine and half ATG plus cyclosporine plus eltrombopag. Does finances differ?
Almost
6 months. I don't think 6 months of eltrombopag.
Yeah.
And you are reducing half ATG, so cost, I think it comes same. No?
Yeah, it's the same, because with the patient assistance program for 6 months of cyclosporine, it costs me around 2.5 lakh if I give it a dose of 150 mg. So when I compromise my eltrombopag for 6 months, so I try to put eltrombopag into the regimen as much as possible. So that is the next slide, please. Next slide. Next slide. Next slide. So eltrombopag reinitiated in this case, and I'm awaiting a response. Kidney was on the higher side. Nephrology consulted taken, but advised renal biopsy. The platelets was 26,000. I just hold the renal biopsy here. Next slide. I would like to go to the last case. Please run on to the last case. Next slide. Next. Next case. Yeah. This is my last case, 46 years male, no comorbidities, diagnosed required aplastic anemia, PNH negative in August 2020. There was a meaty sibling donor available. We did an allogenic transplant in November 2020. Conditional management, flu-side, rabbit ATG, GVHD prophylaxis, cyclosporin methotrexate, stem cell source, bone marrow harvest. Complications, she had a febrile neutropenia. She has a thrombosis on day 30 because we do transplants with an IGV line and grafted day 40. Next slide. My last slide. Next slide, please. In the second month of BMT, she started dropping her counts. There was no sepsis, no secondary cause of cytopenias, CMV PCR negative, marrow was done, which was hypocellular. How do we go about with this case? Any of the panelists can take this question. So second month of transplant, she recovered counts, she engrafted, and then the second month of transplant, the counts starting dropping down, all secondary causes ruled out. We did a, next slide, please. We did a chimerism, that was 85% donor chimerism. Discussed options of retransplant, patient has limited finances, no finances available. We need to revise this patient. What next? Dr. Upendra sir, Dr. Pawan, anyone can take this question.
Yeah, I'm Dr. Pawan. So basically, 2 months post-transplant, this patient is having falling chimerism, 85%. So we have basically, it is difficult to see always the rejection, particularly in non-malignant diseases. It is very difficult to manage. So what I would like to do here in this case is initially, first I would like to cut down the immunosuppression and watch for chimerism again. So that is the one thing. And if suppose it is say not responding to that, then probably we can think of adding DLI also.
Okay, the patient does not have any finances for a retransplant or a DLI.
The DLI is not costly. It is less than that, very much less than the transplant cost. So instead of losing this chimerism, so that's what I'm saying. So first, I would like to cut down the immunosuppression. And then if the patient is not responding, probably maybe 1 month we can watch, repeat chimerism after 1 month of cutting down immunosuppression. And then option of DLI can be given to the patient.
She drastically started dropping down the counts. There was no time. I mean, it was like she was just crashing the counts.
So that's what I'm saying. So this is what else we can do? So we cannot let the chimerism go down. So we have to first intervention. What we can do is cut down the immunosuppression, watch for blood counts, watch for chimerism. If not, then DLI is an option. Otherwise, we are going to lose this graft.
Next slide, please. Next slide, my last slide. Next. So we initiated the patient on L-Thrombopag 150 mg OD. Reduce the dose of cyclosporin, but continued on the low dose cyclosporin. We got a partial recovery, the counts were achieved. So there is some literature, good literature, which shows role of L-Thrombopag in a poor graft function in aplastic anemia. Any comments by any of the panelists here? L-Thrombopag usage in poor graft function post-transplant.
Dr. Radhika, this patient is likely having, as Dr. Pawan said, a falling chimerism. For poor graft function, yes, L-Thrombopag does as a role in improving overall stem cell abilities and improving the counts. But for this patient with falling chimerism, I will be a bit suspicious of adding L-Thrombopag just to improve the counts.
No, L-Thrombopag, L-Thrombopag can be added, but my question in this patient would be, at this point of time, what was the chimerism? Whether the chimerism stayed same or improved or fallen further. So that I would be interested in knowing.
85% donor chimerism at second month is not a real great falling chimerism, right?
So that's what I'm saying. After initiate, you are saying the patient, there was partial recovery of blood count achieved in how many days? In whether it was achieved in 15 days, 1 month. So what was the status
in 2 weeks? In 2 weeks.
So what was the status of chimerism at this point of time?
Thank you, Radhika.
I would be curious to know what was the chimerism at this point.
Okay, Radhika, we have run out of time.
Next slide. Yeah, next slide. Thank you.
Radhika, we have run out of time.
And that's a thank you slide, sir. Next slide. Thank you very much. Thank you, sir. Thank you for this opportunity.
So we move on to the second part of this session. And we have lecture on L-Thrombopag and severe aplastic anemia in 2022. The guest speaker is Dr. Regis Lotta. He's from Hospital St. Louis, Aplastic Anemia MDS International Foundation, France. I invite him to give his lecture.
Good afternoon, everybody. I'm very happy to be with you today. Just the time to charge my lecture. Yeah, it's here. So you should see it now.
Yes.
Okay, great. And are you seeing my disclosures? Okay, great. So my task today is really to speak about L-Thrombopag and severe aplastic anemia in 2022. As you know, there is a little bit of change, and I will begin by first line and will come then to patients with refractory aplastic anemia. So first of all, those my disclosures. Well, basically what we have to keep in mind is that L-Thrombopag in aplastic anemia was really not a drug that we would like to use, since the thrombopoietin level in our patients was very high. As you can see here, was some studies done by NIH and showing that the thrombopoietin were even higher than MDS and LC controls. However, coming from the bench, we have some clues to think that L-Thrombopag would have been interesting. First of all, we know that the TP receptor is essential for thrombopoiesis. Then we know that the receptor is also expressed by stem cells. There was also some evidence is coming the mouse showing that knockout mice have a reduced number of hematopoietic stem cells. And finally, but not last, I would say that patients with congenital megakaryocytosis are presenting bone marrow failure. So basically, I just would like to recap the place of L-Thrombopag in the algorithm of treatment of patients with severe aplastic anemia. As you can see here, it's coming after a sibling transplantation. So in other words, the first questions which would rise in front of a patient who is presenting to you with severe aplastic anemia is if is age less than 40, if you have a sibling donor, and then he has to go to transplant. There is no place for L-Thrombopag in that situation. The patient should be transplanted as soon as possible. And then if the situation is the other ones, so older than 40, or patients who have no siblings available in the family, then we can discuss about immunosuppression. And for years now, since 30 years, as you know, the reference treatment was ORS ATG plus cyclosporine, ORS better than rabbit. That's been published in the New England Journal 2011 by Philip Scheinberg from NIH. And so that's this platform that everybody was trying to improve since decades. And honestly, there has been a bunch of studies that was trying to foster the response rates of our patients with idiopathic aplastic anemia. First of all, there was other drugs than ATG or cyclosporine. We used androgens, we used high-dose steroids. There was nothing that was showing any efficacy. There has been a bunch of literature in some conflict research results on the use of cyclophosphamide with moderate or high dose. There has been some randomized trial from NIH that has been stopped because of toxicity. So now I would say that Cytoxan has no place outside transplantation, and it's clearly not a treatment we could use for immunosuppression itself. Because idiopathic aplastic anemia is an autoimmune disorder, there's also been a bunch of studies, at least 2 studies, prospective clinical randomized trials using mycophenolate mofetil, MMF, or sirolimus added to the platform of ORS ATG plus cyclosporine. And as you can see here, in the randomized setting, there was no improvement in terms of response rates and overall survival. And finally, there has been a European study that was run in 2010, around 2010, by Tikeli and all European colleagues, adding GCSF to the platform of ORS ATG and cyclosporine. Again, it was a randomized international trial. And again, there was no improvement in terms of response rates and overall survival. So in this context, as you may imagine, eltrombopag first line came to the place. And also because, as you know, in 2012, there was some interesting results in patients with refractory aplastic anemia. There was this phase 2 prospective clinical trials run at NIH, published in 2017 in the New England Journal, who was suggested that possibly eltrombopag might be interesting first line in patients with severe aplastic anemia. The standard treatment was the association of ORS ATG plus cyclosporine from day 1 to month 6. And then there was 3 schedule of eltrombopag from day 15 to month 6, or from day 15 to month 3, or for cohort 3, what we call the total therapy, from the 0 altogether, ORS ATG plus cyclosporine plus eltrombopag. So what are the results of this study? First of all, let's come back on the criteria for response, because there is some discrepancy according to US investigators and European investigators. For complete response, we all agreed on those criteria. It's not normal CBCs, is presenting with platelet counts 100,000 neutrophils at 10 grams per deciliter at 6 months. We all agree on those criteria. For partial response, there are some discrepancies. Since we in Europe consider patients in partial response if they are not transfused anymore, while in the US, partial response is considered if blood counts are not meeting criteria for severe aplastic anemia or if patients are in complete remission. So in other words, if you have one improvement in one lineage, but you are still transfused, you are considered by our American colleagues as a partial responder, while in Europe, you are considered as a refractory patient because you are still transfused. I'm sorry to insist on those classifications, but this is really helpful when you're reading our papers to understand why sometimes our results are different. The other thing that is important presenting this phase 2 trial was how they compare the results they found to patients, historical controls treated on the same site, NIH, prospectively, mostly randomized trial. And as you can see, what they were observing in those historical controls core of patients was a complete remission at 6 months of 17% and an overall response of 68%. So basically, as you can see on the right side of the slides, when you are presenting in blue, in the 3 cohort of patients, some response rates about 80, 87, or 94%. This is outstandingly high. And basically, what we could say is that it's more higher than what is expected, usually 68%. Even in terms of complete response, you could see that 33%, 26%, 35% of 58% of patients are in complete remission in the 3 cohort of patients, which is far higher than the 17% that was expected at 6 months outside the use of eltrombopag. So basically, from that trial, we had the feeling that for the first time in history, at least in the last 30 years, eltrombopag added to ORS ATG plus cyclosporine might improve drastically the response rate of our patients. However, as you know, there is many phase 2 trial who showed that in the end did not succeed in a phase 3 setting. So basically, it was not the case for eltrombopag, and we just published in New England Journal the results of this phase 3 international academic trial run by the EBMT group. And what we did is to randomly assign our patients to the standard treatment, ORS ATG plus cyclosporine, compared with experimental treatment, the same one, added eltrombopag. And what we decided, as you can see here, is to use the eltrombopag at day 14 until 3 months if patients were in complete remission, or at 6 months if patients were presenting with partial response. So in other words, the idea of that trial, and we have to keep in mind that it was designed almost 10 years ago, the idea of that trial was to expose the patients as less as possible to a trauma pack that we didn't know at that time that might be benefit for the patients. And we didn't know also that it might be not safe for the patients. That's the reason why the exposition was less as possible. The primary endpoint was the complete remission at 3 months for the same reason, to try to not expose the patients longer at the drug. And as you can see, the key secondary endpoints were really the ones that we are using usually speaking about aplastic anemia. The force of that study was obviously stratifications according to what we know that is playing a role in severe aplastic anemia, disease severity, severe versus very severe, age, 40 years of age versus younger, and center. We also decided to have a stratification according to centers because we have some reference centers who are including a lot of patients and some others that might include it less. And that's the reason why we also included this in the stratification factors. So here are the definition in that study. And as you can see, for the complete remission criteria, there was no difference. However, for the partial response criteria, that's what I told you before, we were prone to consider patients with a partial response if they were transfusion independent. So in other words, first of all, you should not meet any longer the criteria for severe aplastic anemia definition, but you should also be transfusion independent. And we choose this criteria because in my mind, this is what is really reflecting the benefit that the patients is giving from immunosuppression, is not any longer coming to you as a hospitalization, but is coming to see you in clinic for a few minutes. For the non-response criteria, we were considering for patients who were not meeting, of course, CR or PR. Clonal evolution was also defined morphologically or karyotypically. Basically, patients should not, of course, present with acute leukemia, myelodysplastic syndrome, or new karyotypic abnormality. And we also take advantage of two samples at 3 months interval. One karyotypic abnormality, isolated, not reproduced, was not considered as a karyotypic abnormality. And as I told you, the primary endpoint was a complete response at 3 months. And basically, we decided that we could consider the study positive if you were triples the primary response to 7% to 21%. So what is the difference of the RACE trial compared to the NIH study that has been published in New England in 2017? First of all, the first one is a randomized trial. The other one is a non-randomized historical control trial. We have also a very important difference in terms of cyclosporine duration. It was only 6 months, a full dose for NIH, while for us it was 1 year, and then we decreased and stopped at 24 months in both studies. As I told you, we tried to have the less exposure to a trauma pack as possible. So basically, we got a 3 months treatment if patients came to complete remission, or 6 months if they were not in complete remission at 3 months. The primary endpoint was complete remission at 3 months to be sure that all patients who entered in the trauma pack arm received full dose for 3 months. And the criteria for response, as I told you, and this is from far the most important, were transfusion independency for partial remission criteria in the EBMT study. As you can see, we did not include young patients, only 15 years of age or older. And the median age of our patients was about 53. This is obviously around the age that we have in Europe for patients eligible for immunosuppression. So now what are the results? So first of all, those are the countries that participated to the trial. So as you can see, there was UK, there was Netherlands, there was France, there was Spain, Italy, and Switzerland. Unfortunately, we were not able to make Germany join that trial because of regulatory purposes since there was 2 experimental drugs at the moment of the opening of the trial, which is not suitable for PI, which is the regulation agencies in Germany. So finally, we were able in those 6 countries to include 205 treatment-naive patients with severe aplastic anemia, and the median follow-up was 24 months. So as you can see here, 205 patients were registered. We were not able to randomize 3 patients because of 2 deaths, and also because of 1 misdiagnosis, sarcoidosis for 1 patient. At the end, 202 patients were randomized. There was 5 exclusions, 2 patients because they were diagnosed with moderate aplastic anemia and not with severe, and 3 other patients, 2 because they were finally diagnosed with MDS and was with AML. Finally, we got 197 patients who were eligible for analysis, 101 in standard arm and 96 in the experimental treatment. Here is the characteristics of the patients. As you can see, that is well balanced. Obviously, age and severity were part of the stratification, so this is quite normal. In terms of sex ratio, we're not so bad. And in terms of PNH, as you can see, there was 45% of patients with a PNH clone in arm A and 35% in arm B. Here is the primary endpoint results. As you can see, the results was positive. We observed a significantly higher chance for response using eltrombopag at the top of ORS ATG plus cyclosporine for patients at 3 months. Basically, the patients in arm A have a 10% response, complete response rates versus 22% in arm B, means that the chance for response was 3 times higher, and that was significant. In terms of overall response at 6 months, you can see that it was about 45% in arm A and 72% in arm B. Again, there was almost 4 times higher chance for response in the patients who received eltrombopag plus ORS ATG plus cyclosporine. So as I told you before, you could be surprised about this 45% overall response in the standard arm. But as I told you, we decided on purpose to exclude patients for partial response criteria if they were still transfused. If now I'm reclassifying the response rates according to NIH criteria, considering that transfusion patients might be included as partial responders, if they improved at least 1 lineages at 6 months, you can see that we have exactly the same results that NIH published. For the standard treatment, it's about 66%, 3 months and 6 months, while for the experimental treatment, we have almost 80% of patients who are responded at 6 months, which is still significant. I didn't have time to enter in the quality of the response. There was higher patients with complete response. There was a response rate that was quicker. And so that means that patients were responding better, quicker than the standard treatment. More importantly, the patients were not only responding quicker and better, but there was also no safety concern in that trial. As you can see here, the serious adverse events presented in each arm, A and B, were very similar, and the patients coming off study primarily because of transplantations was the same in both arms. So, of course, as you may imagine, since eltrombopag is a TPO receptor agonist and considered as a growth factor, we were very vigilant on the clonal evolution possibility. So we were checking patients very regularly, and we were banking those patients at baseline at 6 months post-treatment, but also at 2 years. And what we did find is only 4 patients who presented with a cytogenetic transformation considered as MDS according to WHO, with 2 patients in arm A and 2 patients in arm B. As you can see, there was an exact similar distribution between both arms. As I told you, we were also looking for molecular biology transformation in at least clonal evolution, or what I would say myeloid cancer genes mutations. And there was still some surprise in this setting, since we did not find any differences between arms, as you can see, baseline 6 months or 24 months. We were not having any difference between standard treatment and patients who receive eltrombopag per source ATG plus cyclosporine. But we did see a significant number of patients in both arms who were presenting with myeloid cancer gene mutations. And that was about 30% baseline and 60% at 6 months after immunosuppression. As you saw before, we did not expect 60% of AML or MDS. So this is just highlighting that clonal evolution in the context of aplastic anemia is far different from what we are observing in MDS or AML. In other words, when you have a myeloid cancer gene mutations, the MTT3A or XXL1 or RANKS1 or even TP53, the meaning is certainly not the same than if you find these mutations in the context of AML and MDS. So this study was able to show that eltrombopag reached to higher, quicker, better response rates in patients without any clinical safety concern and also no biological concerns. Of course, we look for fatal cases, and there was about 14 in arm A and 8 in arm B with no real difference. That was not significant. And in conclusion, this study was able to show a significant increased response rate in patients receiving eltrombopag. The primary endpoint was reached. There was no safety concern. And as you saw, there was no higher rates of somatic mutations in arm B versus arm A. We just show that in aplastic anemia, there is a high rate of somatic mutations per se that need to be explored in the future. Finally, I would say, last but not least, clonal evolution occurs usually 10, 15 years after diagnosis. And what we are doing now is to follow carefully those patients prospectively to see if in 10 years from now, there will be higher rates of clonal evolution, namely AML, MDS, for patients who are exposed early to eltrombopag. So just to now summarize, the reference treatment for patients who have not sibling donor, who are not eligible for transplantation upfront, is also ATG plus cyclosporine plus eltrombopag. We might, of course, discuss the schedule of eltrombopag should be given at D0 or should be given at D15. The time that patients should be exposed to eltrombopag, those things that are not, I would say, fixed in the marble so far. Of course, that might be part of the discussion. So then what should we do with the patients with refractory to immunosuppression? I would say that first of all, the two things that you have to do is to verify that the patient is not already in a clonal evolution state. So you have to do a marrow sampling again. This is most of the time at 6 months after the beginning of immunosuppression. And of course, to check morphology and cytogenetics in those patients to be sure that they are not already at a stage of clonal evolution that would probably motivate transplantation straightforward and not another immunosuppressive treatment. The other thing that you have to verify is that the patient is not presenting with an inherited disorder. So in other words, you have to verify that you did not miss a constitutional disorder and that the patients have not been diagnosed with a Fanconi anemia or dyskeratosis congenita that will explain that he is not responding to immunosuppression. If the patient is still at the aplastic stage, and if the patients have a 10 out of 10 donor or is young, it should be transplanted. There is no space anymore for a second course of eltrombopag, whatever. For young patients, transplantations might be curative. So this is really something that you have to keep in mind. If the patient is not presenting with a match unrelated donor, if he's not young, then you have to consider eltrombopag. Of course, at the moment, the place is very difficult because those studies that I'm presenting to you right now have been developed while patients have never been exposed to eltrombopag before. This is most possible that the patients in the next future will probably be exposed to eltrombopag from first line. And then, of course, the discussion for refractory patients might be a bit different. However, from those two studies for refractory patients that has been developed in 2012 and 2014, what has been clearly showed, and it's here on the stage, is that the response rates expected in refractory patients was about 40%, with some patients who were presenting, and that's very important, a 3 lineages response. And what we do observe is that in patients who are responders, 30% of them are presenting a response at best response follow-up in platelets, hemoglobin, and neutrophils. What we did in France is a real-life study that I'm presenting to you right now. The paper has been published in Hematologica, and we were using also eltrombopag. Why it was not used first line, obviously, because we just published the paper first line. And what I'm reporting here is patients like NIH study, patients who were never exposed to ATG. So there was really a first line cohort in 8 older patients, as you can see, cohort A. Patients was about 73 years of age, and a cohort B, refractory patients, I would say like NIH papers, patients who were already exposed to ATG, about 35, with a median age like in the RACE trial, 53 years of age. What we did found in that study, it was first of all, the use of eltrombopag was safe, but again, it was not a prospective clinical trial. So of course, all those results has to be taken with precaution. There was no monitoring. It was just reported by the centers. And this is real life studies that we need also, but we should take this with precaution. However, we found exactly the same response rates in those refractory patients of what has been reported in prospective clinical trials, namely 40%, with basically patients who were responded at 3 months for those ones who has been already exposed to ORS ATG plus cyclosporine, and 6 months for older patients that could not receive ATG, reason why they received cyclosporine plus eltrombopag first line. The other important characteristics and results from that core of patients is that, again, 1/3 of the patients responded in all lineages while treated with eltrombopag. Finally, we did find an interest to increase the dose from 150 milligram, which is our standard, to 225 milligram for 3 months more, and that might be a response rate for 20% of the patients. And we also added Revolade to ATG plus cyclosporine as second immunosuppressive treatment in patients that was also associated with a high rate of response. Finally, what I did find interesting in patients with refractory aplastic anemia is that we could even stop the drug in some patients. Of course, in the patients who were refractory, we stopped straightforward. 15 patients who did not respond. We have 1 patient who stopped because of liver toxicity. We have 4 patients that we were able to stop because they were in robust response. So what is response? Robust responders, it's when your platelets is more than 50,000, hemoglobin level more than 10 grams per deciliter, and neutrophils more than 1,000. And what we were doing in those patients is to decrease the dose 50% and then see if they are still with a stable response, if they are still with robust response at 8 weeks after decreasing. And if it's the case, then we stop the drug. And from the 4 patients who stopped at the time of the paper, there is only 1 or relapsed and then developed an MDS and died. But for the 3 others, they are still off drug since then. So of course, since I'm a transplanter, I could not speak about alternative transplantation. I'm not gonna, of course, detail this approach, but what I would like to say to you is that if a young patient is refractory to immunosuppression, there is a bunch of trends that in the next months or years, it will be also already been exposed to ORS ATG plus cyclosporine plus eltrombopag. So in that situation, we will consider for alternative transplant, namely cord blood or APLO. In other words, in patients aged 18 years or less, we have a clear less toxicity from transplantation. We know more and more that the approach is safe, and we are coming more and more oftenly to transplant to cure those patients and not to make them exposed to the risk of relapse, cyclosporine dependence, development of a PNH clone, and all those things that are not very easy to manage long-term when you are diagnosed at the 14 or 15 years of age. I will finish my talk there. just to say that first line, if you have a donor in the family, a matched sibling donor, the first line choice is definitely transplantation as quick as possible for patients who are younger than 40 years of age. In all the other cases, for patients with severe or very severe aplastic anemia, the reference treatment is ORS-ATG plus cyclosporine plus eltrombopag. We may discuss the schedule of eltrombopag that is not fixed in the marble yet. For refractory patients, again, if we want to cure the patients, we should transplant them. For patients aged less than 30 years of age with a matched unrelated donors, there is no reason not to transplant. For patients aged 20 years or less, we are going more and more to transplant using Aplo first and possibly cord. We published this in 2018 because, again, in young patients, you want to cure and toxicity from transplantation is really less. And finally, for all the other patients, we are using eltrombopag, but again, with the limitations than in the next years, probably more patients will receive the association of eltrombopag plus ORS-ATG plus cyclosporine first time. With that, I'd like, first of all, to thank you for having listened to me, and more than happy to, of course, take questions. And I would like also to thank all the colleagues who are working with me at the French Reference Center at the national level, but also at the EBMT level, because the RISE trial was led by the Severe Aplastic Anemia Working Party from EBMT, the academic level, and that need to be thanks right now. Thank you very much for your attention.
Thank you so much, Dr. Regis, for that wonderful talk and updating us in this field. We have some of our colleagues here. They may like to ask you some questions. You can open your videos, raise hand, ask questions. Meanwhile, can I ask you one question? Any comment on the non-severe aplastic anemia using eltrombopag-based therapy?
Yes, so the non-severe patients are responding better to immunosuppression. I would not consider cyclosporine alone because what is really impacting patients long-term is the quality of the first response. So in other words, I will consider to give them ATG plus cyclosporine. For the moment, honestly, I'm a bit reluctant in those patients to give them eltrombopag plus ATG plus cyclosporine because, again, non-severe patients respond far better to immunosuppression. So for those patients at the moment, we are using ORS-ATG plus cyclosporine. So no cyclosporine alone, but no triple therapy, but a real chance with ORS-ATG plus cyclosporine. We should probably run the prospective clinical trials, but you know, it's not so easy.
Any comments on giving eltrombopag and cyclosporine without ATG?
Yeah, so that's really something that we are using more and more. There are some studies going on that has been presented as posters for the moment, but should be published soon. One that is from South America, who is really assessing this association, and another one that is still ongoing in Europe that is called EMA. I think that some of our patients are not able to receive ATG. They are not in good conditions. They have kidney insufficiency, comorbidities, transplant problems, cardiac problems. So in those patients, mostly older patients between 70 and 80 years of age, we are really trying eltrombopag plus cyclosporine. Cyclosporine, we are really trying according to kidney toxicity, but we are using eltrombopag for sure, and we have some good results. So I would say that for older patients, this is really a good alternative to avoid high rates of toxicity if we are using ATG.
Thank you. Ashutosh, your question.
Thank you, sir, for your nice presentation. What is your opinion about use of danazol in aplastic anemia patients?
I think this is an efficient and cheap option. So basically, we got some good results using these drugs, especially in inherited disorders, dyskeratosis congenita or Fanconi anemia patients. In idiopathic aplastic anemia patients, I would say that the three lineages responses are more rare. We most of the time have some responses in platelets, but or red cells, but it's rare to have a three lineages responses. the toxicity long-term with liver tumor is something that we have to be aware of. But, you know, since patients will probably receive the association of electropac plus cyclosporine plus ATG first line, and that, of course, refractory patients won't be able all to be transplanted, I think it's going to be a reasonable option second line for our patients, and it might work. So I'm not closing the door. We have an EBMT study going on a large bench of patients to, I would say, reanalyze this option in our patients. I hope that it will be presented at ASH this year. And this is really something that we have to consider, because at the time we have to offer what we can for our patient. And if the triple therapy is not working, if the patient is not eligible to transplantation, we have to find a way.
Thank you, sir. Thank you. My next question is, are you using mycophenolate in aplastic anemia patients?
Never outside transplantation. So in other words, we have a randomized trials that showed that adding mycophenolate to ORS-ATG plus cyclosporine was not adding anything. And this is a drug that is very cytopenic. I mean, patients are presenting cytopenia, so we are not using in aplastic anemia.
Thank you, sir. Thank you.
Right. There are some of these reports on romiplastin-based treatment from Korea. And I understand some studies are going on in the Western world as well. Any comments?
Yes, we have a nice study coming from South Korea in refractory patients with romiplastin that showed some response, but at a 20 microgram per kilo. We reported on behalf of the French reference centers 17 patients with only one response, because we were using at 5 microgram per kilo. So what I do think is like what we are seeing with ITP and severe aplastic anemia, we are using for electropac 75, 150. We should do the same with romiplastin. So it might work, but it has to be higher dose than in ITP. So I would say that for the moment, of course, there is no study first line. It's ongoing. Amgen is running it. So it's going to be interesting to see. But for refractory patients, you might try, but please try higher dosage, at least 20 microgram per kilo, sub-Q once a week.
Right. Anybody else has any question for sir? In that case, I think so. Thank you very much.
My pleasure. It's always a pleasure.
You have been always our friend, and you have always said yes to whenever our request came to you.
Yeah, I'm very happy to share and discuss with you. I mean, if I can do it next time, no problem. A pleasure for me.
Maybe we will call you over to India.
Thank you very much. Take care. Bye-bye.
Bye. And friends, I don't see Dr. Ganesh here, who was supposed to give a little talk. Ganesh, are you there? No. So as Ganesh is not there, I think we come to an end of this 3 days webinar on 6 very important subjects supported by Novartis. We had galaxy of 6 international speakers who spoke to us during last 3 days. We had Indian colleagues who participated very actively. We had a very fruitful discussion. Also thank our event management team from Perfect Square, Yash and Kalpesh, for a flawless control of the situation. And all the audience from India and probably 20 to 25 countries all across the world who have logged in for 3 days continuously. And I suppose this must be a good step in the direction of educating our community. So thank you so much. Good night to everybody. Bye-bye.